Every 2 minutes, a person dies from sepsis. Early recognition and improved implementation of best practices would definitely reduce morbidity and mortality. Our next speaker is here as a voice for sepsis to speak about it and enlighten us. I have immense pleasure to welcome Dr. R. Sadashivam sir and Dr. K.P. Revisa to the dais as chairpersons of this session. Dr. R. Sadashivam sir was graduated from Government Thanjavur Medical College and was postgraduate in General Medicine from Coimbatore Medical College. Currently, he is a chief doctor of Priya Hospital, Erode. Dr. Revisa is a consultant intensivist and physician and the managing director of Nalan Hospital. He did his MBBS from Stanley Medical College, Chennai, and MD General Medicine from Madras Medical College. He has also completed FNP in Critical Care Medicine from Apollo Hospital, Chennai. He was awarded the Best Trainee of the Year 2009 by Apollo Institute of Critical Care Medicine. He has also made numerous publications and posters. We welcome you all, sir.
Good evening and welcome to the session. We know the sepsis is very important part in ICU management because it is very important for the patient outcome. We know that sepsis is presence of any organism like virus, bacteria, fungus. This is simple sepsis causing immune response. And severe sepsis, the presence of organism, extreme immune response lead to organ failure. And septic shock, we know that in association with extreme immune response causing hypotension and hemodynamic abnormality that leads to multi-organ failure and death. So what we do? We take usually blood sample and waiting for the result. So what antibiotics should be started empirically? So now we welcome Dr. M.N. Sivakumar. He studied MBBS in Coimbatore Medical College, a DA in JJM Medical College, and he worked in Sundara Medical Foundation. He is a good teacher and ATLS provider. So we welcome Dr. M.N. Sivakumar to give him lecture.
Thank you, sir.
Thank you.
Good evening, everyone. I would like to thank everyone who's staying back. I think you're compromising your Sunday nap and you're staying here. And it's always nice to be in Erode, I think, because I did my schooling in Erode and a lot of my anesthetists over here are my teachers. Some of them are my good friends. So I always feel like to be in hometown whenever I'm in Erode. And I'd like to thank Sudha Hospital and ISA Erode for this opportunity. Greetings from Coimbatore and greetings from my institution, Royal Care Super Specialty Hospital. I was asked to talk on all these things. I'm sure, I think for want of time, I won't be able to complete all this. So what I will do is, in the next 20 minutes, I'll be talking on what is new in sepsis, mainly focusing on the Surviving Sepsis 2021 guidelines. Let me start by acknowledging my teachers, Dr. Ram and Dr. Mahendran, who taught me critical care, and Dr. Selvajan sir, who taught me anesthesia. To start with, sepsis is a clinical syndrome. It consists of clinical, biochemical, and pathological abnormalities which are induced by infection. I'm sure all of us in the hall will agree it is one of the major public health pattern at this point of time. And this increased incidence of sepsis is due to the increasing aging population and associated comorbidities, and probably we are diagnosing more and more sepsis in a better way in the recent decades. Like any other chronic illness, sepsis is also associated with long-term physical, psychological, and cognitive disabilities. So this is Indian data. This was published in JAMA, and it says sepsis is one of the common indications for ICU admission, and the mortality in sepsis could be as high as 60 to 65%. Let me take you through the definition of sepsis. I think this is how the sepsis definition have evolved over the last 3 decades, and our pathophysiological understanding of sepsis has also evolved in the last 2 to 3 decades. This is how it started in 1992 in the ACCP and Society of Critical Care Medicine conference, and there they defined sepsis as a continuum of illness. You have a whole spectrum starting from SIRS to septic shock. To start with, SIRS is nothing but a systemic inflammatory response syndrome. You should have one or more of the following to diagnose somebody to have SIRS. So they should be hypothermic or hypothermic, they should be tachycardic, they should be tachypneic or have respiratory alkalosis, or they should have leukopenia or leukocytosis. So if you have one or more of the following, then we call them to be in SIRS. If these patients with SIRS, you presume or you confirm the etiology to be infection, then we call it as sepsis. And if these patients have organ dysfunction, hypotension or hyperperfusion, we call it as severe sepsis. And when these patients have a hypotension, which is refractory to fluid resuscitation, and they need vasopressor, then we call it as a septic shock. I think this is how we define sepsis in very early in 90s. When we had the next definition of sepsis, that was in 2001, I think nothing much of change, but we started to realize the pitfalls in SIRS, particularly with regard to the non-specific nature of SIRS. So if you take 4 out of your 5 patients with SIRS in your ICU, they did not have sepsis. I think this was very alarming because the SIRS have a very non-specific nature. I think we can all imagine in our day-to-day ICUs, patient with myocardial infarction, patient who come in a post-operative state, patient come with polytrauma, patient with pancreatitis, all of them will have SIRS, but they will not have sepsis. So people started to realize that SIRS is very non-specific. So in 2016, we got the further newer definition of sepsis, or we redefined sepsis, and this time we included host response. I think this is the first time we included the host response when we defined sepsis. So sepsis is nothing but a life-threatening organ dysfunction due to a dysregulated host response to infection. I'm sure all of you will agree, and this is the first time we included host response when we defined sepsis. And SIRS was discarded and severe sepsis became redundant because even in sepsis, the organ dysfunction was included. So to diagnose sepsis, you should have 2 or more points in SOFA score. I will explain you in subsequent slides what is SOFA score. And these increase in SOFA score with 2 points or more is associated with increased mortality. So what is septic shock? I think it's similar to the earlier definition. Whenever you have a patient with severe sepsis who are hypotensive despite fluid resuscitation and they are needing vasopressors to maintain your mean arterial pressure more than 65, we define them to have septic shock. So this is what I mentioned about SOFA score. So it included all the systems, including coagulation, and based on the patient variables, you give a score, and if your score of that particular patient is more than 2 points or more, then we define them to have sepsis. I think quick SOFA is we call it as a poor man SOFA, or it is an offshoot of SOFA. I think when it came, I think it had a lot of attention, but we sooner realized the pitfalls of QSOFA. But this included only 3 clinical variables. You do not need any of the laboratory investigation. This is used for screening patients in an outpatient setup or inpatient setup, but this may not be very useful in ICU. I think this is how you could operationalize the SOFA and quick SOFA criteria, and you can diagnose patients with sepsis and septic shock. So this is in summary. So we all started here. So when we started, we had SIRS, we had sepsis, we had severe sepsis and septic shock. But when we redefined sepsis, I think SIRS was removed, severe sepsis was removed. Now we have only sepsis and septic shock. So only the good thing is we took into account the host response. I think this is very, very important because we have a patient in ICU. The first day we start on pip-daso. the next day we start on meropenem, fourth day we start on colistin. Because we do not understand, this may not be due to the virulence of the organism or an organism which you are not covering. This could be due to a poor host response. I think this is very important, and this in 2016 definition and the host response was included when we define sepsis. I think I will not waste much time on, this is more of a theory. So whenever the pathophysiology of sepsis, it includes vasodilatation, the release of inflammatory mediators into circulation, endothelial dysfunction, but all of this culminate in a poor microcirculatory flow. This subsequently lead to organ dysfunction and organ failure. The next part of my talk is about the Surviving Sepsis campaign. This is an international campaign. This is aimed to minimize the mortality and morbidity with regard to sepsis. It was initiated by the International Critical Care Societies. They want to minimize the mortality and morbidity with regard to sepsis. In an attempt to do that, they initiated that campaign. And what they did as a part of this campaign was they reviewed the literature at every point of this time, and they came up with the guidelines to make a practice uniform in managing patients with severe sepsis. So at multiple time points, I think we had various guidelines from the Surviving Sepsis campaign. One good thing which happened after 2000 was, I think the industry was taken out of these guidelines, and so I think we could have more confidence that these guidelines could be unbiased. I think subsequent slides I will be discussing about the 2021 guidelines. This is the guideline. This is very exhaustive. I will not be able to discuss every part of it in detail. I would discuss with you whatever is very relevant for our day-to-day practice. To start with, initial resuscitation of patients with severe sepsis or septic shock is like any other stroke or a myocardial infarction. I think this has to be time-bound, and you have to start the resuscitation as early as possible. And initial resuscitation, the guidelines recommend to use crystalloids, and the volume they recommend is about 30 ml per kg, and this has to be given within the first 3 hours. All these guidelines are guidelines. The clinician at the bedside has to use your common sense, and you have to individualize these guidelines to each of your patients. And where they derived this 30 ml per kg, I think all of us have searched the literature, but there is no good data backup for it. But the campaign recommends 30 ml per kg as an initial resuscitation fluid, and this should be given within the first 3 hours. And to guide your fluid resuscitation, I think we all, when we started our medical school, I think we depended on more on the static parameters like CVP, but now most of these guidelines recommend to use dynamic parameters to guide your fluid resuscitation. That could be your passive leg raising test for patients who are breathing spontaneously, or you could use a delta pulse pressure or a stroke volume variation, whichever is which is available in your practice to guide your fluid resuscitation. Coming to the timing of antibiotics. So when you have these patients with shock, the antibiotic has to be given in the first hour. Or when you suspect sepsis, I think this has to be given within the first hour. So it's very clear, when the sepsis is definite or these patients have shock, the antibiotic has to be given within the first hour. But if the sepsis is a possibility, I think you're not sure of sepsis and the patient is not in shock, probably you need not rush up and give an antibiotic, and these antibiotic could be given after your evaluation. So do the evaluation, try to rule out any non-infectious causes, and then probably you could give the antibiotic. You can take up to 3 hours. I think this is one of the take-home message. So if you have a patient with severe sepsis in shock, the antibiotic has to go in the first hour. And if your diagnosis of sepsis is not sure, or these patients are not in shock, probably you can take your time and probably you could give the antibiotic in the first 3 hours. This is again another take-home message I would like to give to all the delegates. I think we have started to use more and more procalcitonin. It's a very expensive investigation. It costs about 3,000 to 4,000, and the guidelines reiterates this should not be used to make a diagnosis of infection or to use it as a tool to guide you to initiate antibiotics. So do not use procalcitonin as a guide to initiate antibiotic or to diagnose infection. With regard to your empirical antibiotic therapy, so when you suspect or when you think probably MRSA should be covered, included, otherwise do not include MRSA coverage. So you need to, whenever you are starting an empirical therapy, try to risk stratify your patient. So whether this patient has got a post-viral pneumonia, whether it's an IV drug abuser, whether it's got a skin and soft tissue infection, then probably you need to cover MRSA, otherwise you don't have to give an MRSA cover. With regard to gram-negative coverage, if these patient is in severe sepsis and septic shock, you think that XDR pathogen is a possibility, then probably you have to use a combination therapy. I would like to repeat, so these patients are in sepsis or septic shock, and you could think of the XDR, the extremely drug-resistant pathogen is a possibility, then you have to use a combination therapy, otherwise you don't have to. So when do you think of extremely drug-resistant pathogens? In a patient who was hospitalized in the recent past, who has received multiple antibiotic in the recent past, elderly people, multiple comorbidities, higher severity of illness. So these are the group of patients probably where you will anticipate an extremely drug-resistant pathogen. So otherwise probably you don't have to give a double gram-negative coverage. Once you started a double gram-negative coverage, but you got your cultures, you know the pathogen, it is not a very resistant pathogen, probably you should narrow down your therapy. With regard to delivery of antibiotics, particularly if you are using a beta-lactam antibiotics like a penicillin or a cephalosporin or a carbapenem or a monobactam, probably you should use them as an extended infusion. So all beta-lactam antibiotic, you should use them as an extended infusions. You need to take into account of their stability at the room temperature, but they are more effective when you use these beta-lactam antibiotic as an extended infusion. So if you ask me why, see, you all know that these are all time-dependent antibiotics. So the maximum time you try to keep this antibiotic above the minimum inhibitory concentration, it will be better. It's got a good bacterial killing. That's why you should try to give it as an extended infusion rather than as a bolus. So if you want to discuss this further, I'm happy to do it after this session. For the want of time, I will not be able to discuss further in detail. As far as the de-escalation of antibiotic is concerned, so you have started an empirical antibiotic therapy, 48 hours down the line, you got the culture report, you can make a clinical correlation and decide whether you need to continue the antibiotic. If you think it is a non-infectious cause, whether you can stop the antibiotic, or at least you could de-escalate. Suppose you have started a gram-negative and gram-positive cover as an empirical therapy, so you got a culture report, it is a genitourinary infection, you got a Klebsiella E. coli, at least you can stop the gram-positive cover. If you have started a very broad gram-negative coverage, if it is a very sensitive gram-negative organism, you could narrow down your gram-negative cover. These are very, very important as a part of antimicrobial stewardship. And here, I think procalcitonin could be used as a guide to your de-escalation and as a guide to decide your duration of therapy. See, like to reinforce, so procalcitonin should not be used to make a diagnosis of sepsis. I think we have been using it for many years. So we got a very good data. It has got a lot of limitations. You should not be using it to differentiate between inflammation or infection or to decide on initiation of antibiotic. If at all you have to use, you can use for de-escalation of antibiotic or deciding the duration of antibiotic. And one important practice change we all need to make with regard to antibiotic prescription, particularly keeping antimicrobial stewardship in consideration, we are moving from longer course of antibiotic therapy to shorter and shorter course of antibiotic therapy. And you take it from me, this could be very safely practiced. I think we used to give longer course of therapies for bacteremia, about 2 weeks. Now I think we are coming to 10 days. And similarly for UTI or hospital acquired pneumonia, we are moving from a longer course of therapy to shorter course. As far as hemodynamic management is concerned, it is very clear. The surviving sepsis guidelines recommend to use crystalloids. It is a strong recommendation. I think if you take the entire guideline, I think there are only very few strong recommendations. For fluid resuscitation, they recommend to use crystalloids. It is a very strong recommendation. And now the controversy between crystalloids and colloid has been ongoing, but in 2021 guideline, they have recommended crystalloids over colloids, and it is a strong recommendation. So as far as what crystalloids you use, these guidelines recommend balanced salt solution over saline and ringer lactate. I think my friends over here and I slightly disagree, and we have got more literature. This might change. I think in our day-to-day practice, we do use more of crystalloids like normal saline or ringer lactate for fluid resuscitation. But if you are doing a large volume resuscitation, that is the time we might switch over from a normal saline to a balanced salt solution, considering the huge chloride load. As far as the synthetic colloids are concerned, they give a weak recommendation to use albumin. Suppose you have done a large volume crystalloid resuscitation, you can use a bit of colloid like albumin. As far as the other synthetic colloids are concerned, there is a strong recommendation not to use starch. My anesthetic friends over here, we have got very good data with regard to starch. It is more associated with more renal failure and more need for renal replacement therapy. I think we should think about stopping starch usage, and they've given a weaker recommendation for not using gelatin as well. But I think we do use gelatin as a part of most of our large volume fluid resuscitation. With regard to vasopressor, I think there is not much of confusion over here. There is a very good clarity. I think all of us here would be using noradrenaline as the first vasopressor of choice, and if you are using higher dose of noradrenaline, that is the time probably you should think of adding vasopressin to noradrenaline. And if these patients have a cardiac dysfunction after your fluid resuscitation and attaining good mean arterial pressure, that is the time you think of adding dopamine. I would like to repeat, so noradrenaline is the first vasopressor of choice, and if you are using escalating dose of noradrenaline, add vasopressin to noradrenaline. And if your patient, you attain a reasonable mean arterial pressure, you have adequately fluid resuscitated them, still they have significant cardiac dysfunction, this is the time we think of introducing dopamine. The guideline also re-emphasizes to use invasive lines whenever you have to use a high dose of inotropes or vasopressors. And another recommendation in these patients with severe sepsis and septic shock, when they have cardiac dysfunction, they recommend against the use of levosimendan. I think we come to the end of Surviving Sepsis campaign and guideline. Another important aspect I would like to reinforce with regard to additional therapies in treatment of sepsis and septic shock, they give a strong recommendation against the use of immunoglobulin, blood purification strategies, ulnostatin. So all these are not very useful, they are very expensive, and guideline clearly says not to use these therapies, and including vitamin C. So as far as the antibiotic usage is concerned, I think for want of time I will not be able to go in detail. So the response to fever should not be antibiotic, it should be a clinical evaluation. You should keep in mind all the non-infectious causes as well, and you should do appropriate cultures before starting antibiotic, and start antibiotic very early if these patients are hemodynamically unstable. I think it's more of a repetition, and these aspects has to be kept in mind whenever you're starting antibiotics, whether you're using the right drug, right time, right dose, and right duration. So antibiotics are not magic bullet, and each of the infectious diseases got two components. The one is what is the syndrome you are treating, and what is the microbiological etiology for the syndrome. So if you get your syndrome right, probably you will get your antibiotic right. I think to give a synopsis, so whenever you have a patient with fever in your ICU, what they need is a good clinical evaluation. Do a proper clinical evaluation. Keep it in mind non-infectious causes. Once you ruled out non-infectious causes, send appropriate cultures. So if you think infection as the cause, then probably think of antibiotic. Before that, you have to run multiple things in your mind. So whether it is a hospital acquired or community acquired, and if so, probably what are the syndrome you are going to treat. So whether it is CNS, skin and soft tissue, or genitourinary, or pneumonia. So try to narrow down your syndrome, then you think of what could be the likely organism. So suppose you think it as a community acquired meningitis, and you think pneumococcus as the organism, then you think of what is the susceptibility of pneumococcus in your community, then probably start them on an antibiotic. So all these things should run through your mind before starting antibiotics. So do not start antibiotic as a knee-jerk response. So fever, need a clinical evaluation, need an appropriate cultures. Then you think after sending cultures, so what is the syndrome you are treating, whether it is hospital or community acquired, and then what is the susceptibility of that organism in your ICU. So it could differ from Sudha and probably KMCH or Royal Care, and inside your hospital it could differ between a trauma ICU and a surgical ICU. So run all this in your mind. Also take patient factors into consideration, like what is the age, what is the comorbidities, what is the severity of illness, and whether he is exposed to antibiotic in the recent past, and whether he was hospitalized in the recent past. So all these factors should run in your mind before you start an antibiotic. So these are some of the organisms. They are not fully inclusive of everything, but these are some of the organisms you should try and cover above and below the diaphragm, and these are the gram negatives you should target in the ICU. So Enterobacteria like E. coli and Klebsiella, I'm sure my ICU friends over here will agree. I think we are seeing a carbapenem resistant Klebsiella about 60%. So 60% of the Klebsiella isolated in ICUs are carbapenem resistant. And other problem bug is Acinetobacter pseudomonas, and we are seeing some sporadic resistance to colistin as well in pseudomonas. So there are a lot of fallacies, and I think probably we should try and overcome these fallacies. So if I have time, I will proceed, otherwise I will stop here. Ravi?
You can proceed, no problem.
So I'll have another 3-4 minutes. So antimicrobial stewardship is nothing but a coordinated intervention. It is designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. If I have to simplify, it is nothing but a judicious use of antibiotics. So that's what antimicrobial stewardship is all about. So stewardship means careful and responsible management of something entrusted to one's care. So what will be our goal of antimicrobial stewardship? Our primary goal is to optimize the clinical outcome, minimize the collateral damage like toxicity, selection of pathogenic organisms, or emergence of resistant pathogens. And the secondary goal will be to reduce your healthcare costs. So this will be our primary and secondary goal of antimicrobial stewardship. How do you do that? These are our core strategies. So you do a prospective audit, intervention, and feedback. This is most applicable for private institutions. You could also respect the autonomy of prescribers. So you could do it at the end of 48 hours when the culture results are available. So you can suggest them to stop antibiotic if you think it is a non-infectious cause. You can advise them to de-escalate. If you think it is a very drug-resistant pathogen, then probably you can ask them to get an ID opinion. The other core strategy will be a formulary restriction. I am sure it is not practical in many of our setup. This may hold good for a public sector or for an academic institution. This is very well practiced in CMC Vellore. Some of the drugs are kept in formulary restriction like colistin, tigecycline, linezolid. So these drugs are kept in formulary restriction. So your initial few doses of antibiotic may not be restricted, but subsequently I think there is a stewardship team, they might go through this and they might see the judicious need of it. Otherwise you may not be able to continue these antibiotics which are kept in formulary restriction. So these are the ideal members of our stewardship team. I think all these members may not be available in each of our institutions. So you could, I think, get people who have domain knowledge in antibiotics and who are interested to do this and probably organize your team. And antimicrobial stewardship is a win-win situation for everyone. It reduces the emergence of resistance, it reduces cost, and it improves the clinical outcomes. I think a lot of things are happening in our neighborhood. I think Kerala is a front runner as far as the antimicrobial stewardship is concerned. They got a antibiogram for the state, and they restricted all these pharmacies from giving antibiotic without prescription, and a lot of awareness is being created about antimicrobial stewardship. They are talking about antimicrobial stewardship in outpatients. I think they are much ahead of all of us, and I think we should learn from our neighbors. I would stop with this. A quote from Lewis Thomas: "The microorganisms that seems to have it in for us turn out to be rather more like bystanders. It is our response to their presence that makes the disease, and our arsenals for fighting off the bacteria are so powerful that we are in more danger from them than the invaders." Thank you.
Thank you, Dr. M. N. Sivakumar from Royal Care Super Specialty Hospital, for giving us an excellent talk about the sepsis and ICU management. And any queries from the audience, you can ask. Okay.
Thank you, sir, for enlightening us with your words of wisdom. I hope your presentation will have paved a way to understand the strategies. Thank you once again.
Disseminated intravascular coagulation. DIC is a complicated condition characterized by excessiveness of both coagulation and bleeding. Let us see how to easily discriminate the extremes, control this excessiveness, and bring back the patient to normal homeostasis. May I invite Dr. K.P. Ravi, sir, to introduce our zealous speaker, Dr. V. Dedeepiya Devaprasad, sir.
Yeah, we are pleased to welcome Dr. V. Dedeepiya Devaprasad. He is a senior consultant intensivist practicing at Chennai. He is also the in charge of Chennai Apollo Specialty Hospitals ICU. To tell about him briefly, he has completed his Indian Diploma, Indian Fellowship, and European Diploma in Critical Care. And he is a very good teacher and a good clinician. He has conducted various teaching workshops, and he has delivered a lot of lectures in many conferences. Many students will be very willing to hear his lectures. I hope today's topic, disseminated intravascular coagulation, which is one of his favorite, because he is very much interested in neurocritical care and also hematological critical care, will throw many light about this unrecognized or under-recognized entity in ICU. He is all the way from Chennai to share his knowledge and experience with us. Please make use of it. Over to you, sir.
Good afternoon. Thanks to Sudha Multispecialty Hospital and the E-Road Society of Anesthesiologists and Dr. Amuda in particular for having me here. And good afternoon, chairpersons. I'll be talking to you about disseminated intravascular coagulation. It's basically just understanding the basics of blood clotting. So from a simplified clinician's aspect, you do understand that there is a lot of platelet and coagulation factor activation, a lot of exciting biochemistry that takes place, and ultimately you do have clot formation. Well, in a very, very simplified view, you understand that you do have blood that is flowing. When you have an endothelial damage, the subendothelial collagen is exposed, and this initiates a clot formation. There are three basic aspects of clot. One is a platelet plug formation. Initially, when there is a subendothelial collagen, you do find that there is a platelet plug forming. How does this platelet plug form? Because a platelet has many receptors. One would be the GP2B3A inhibitor receptors, and then you have the GP1B9 receptor. Fibrinogen binds to the GP2B3A receptor and helps to cross-link two platelets. And the GP1B10 receptor, it binds the platelet to the collagen. So platelets bind to platelet, and this is anchored into the collagen, and this causes a platelet plug formation. Subsequent to this, this was an oversimplification. We do have the extrinsic pathway and the intrinsic pathway. We'll just talk about the extrinsic pathway that we know of in medical school in a little more detail. It sufficed for us to understand that you have factor 7 that is activated, and factor 7 that in combination with tissue factor activates factor 10, which activates factor 5, which activates prothrombin, which causes breakdown of fibrinogen into fibrin. All that you need to understand is that the extrinsic pathway is tested by the prothrombin time. So if you have a prothrombin time that is elevated, probably the factor 7 individually is less. Next, we do have understood the intrinsic pathway, where we start with factor 12, factor 11, factor 9, factor 8, and then we come to the common pathway which involves factor 10 and factor 5, prothrombin and again the fibrinogen. Suffice for us to understand that the intrinsic pathway is tested by the partial thromboplastin time or the activated partial thromboplastin time, both meaning the same. This is a simplistic approach that we all learnt in medical school, but actually physiology of clot formation is much more complicated than that, and this is the new theory of coagulation cell-based model, where you have three phases: the initiation phase, the amplification phase, and the maintenance phase. Now, what is the initiation phase? The initiation phase is the phase where there is the initiation of collagen, where there is an injury of the vessel wall which leads to the contact between the blood and the subendothelial cells, which we already know. And this releases a lot of tissue factors, and we know that binds to factor 7. We know that. But what happens is that factor 7 not only activates factor 10 and factor 5, which is a part of your intrinsic pathway, but they also activate factor 9 and factor 9 into factor 9A, which was hitherto thought of forming an exclusive extrinsic pathway. So there is no separate intrinsic or extrinsic pathway. Both factors or both pathways actually merge together at some point of time. Next is the amplification phase, where the factor 10 and factor 5 are formed, and they convert a small amount of prothrombin into thrombin. And generally what we believed is that thrombin will now go to generate fibrinogen into fibrin and the clot forms. But actually, you do find that when the thrombin happens, it activates platelets. And this activated platelet is what binds factor 8, factor 9, and factor 5. And this causes what is called a thrombin burst. So it is no longer simply factor 10 and 5 causing thrombin and thrombin causing fibrinogen to become fibrin. It is actually an activation of platelets, and this activated platelet, which binds a lot of the other factors that are common to both the extrinsic pathway and the common pathway, and this is what causes a thrombin burst. And then we have the propagation phase, where this causes more thrombin to be regenerated, and this causes fibrinogen to become fibrin. And this is what we call as a thrombin burst. So we need to understand that it is not an oversimplification of an intrinsic or an extrinsic pathway, but it's still useful for us to understand that pathway, because we know what the elevation of each of the factors that we measure actually imply. So from thrombin to thrombin, we do have the thrombin burst. So let's look at interpretation of our lab results. As we already said, if you have a factor 7 that is prolonged, you know that it is prothrombin. So if you have a prothrombin that is prolonged, we know that it is an intrinsic pathway disorder. It indirectly means that factor 7 alone is probably wrong in these patients. If you have an activation partial thromboplastin time that is prolonged, we know that individually the factors 12, 11, 10 and 8 are abnormal. If both PT and APTT are prolonged, then we know that factor 5 and 10 are also abnormal. If we know that thrombin time is prolonged, that factor 1, 2, 3 are abnormal. And obviously we look at the fibrinogen by the fibrinogen assay, and very, very rarely we'll have to look at factor 13 in a patient who otherwise has all these parameters under reasonable control but still continues to bleed, that could be because of a factor 13 deficiency, which we assay by looking at a factor 13 screen. We do understand the terminologies of FDP and D-dimer. Usually we use only D-dimer and FDP is not usually used because FDP usually measures primary fibrinolysis. What do you mean by primary fibrinolysis? Whenever you have a clot formation, there is an attempt at breaking down the clot, which is a natural process. So that's called primary fibrinolysis. So if you have a trauma and you have a clot formation in your body, you will have primary fibrinolysis because at some point the clot that had formed had to be dissolved. So that is measured by the FDP and it measures a lot of fragments, particularly factor D and E. But D-dimer is more specifically looking at what happens to the intravascular fibrin formation, and it specifically looks at the fragments that have been formed by the cross-linked fibrin monomers. So they don't look at the fibrinogen and the products that may have derived from the fibrinogen. They looked at the products that have been derived from the cross-linked fibrin monomers. So that's more specific for clot formation. And therefore, D-dimer is preferred over FDP. And moreover, D-dimer uses an enzyme-linked immunoassay in contrast to FDP, which uses only a latex assay. And therefore, always ask for a D-dimer. And when you ask for a D-dimer, insist that your D-dimer comes with an enzyme-linked immunoassay and not with the latex bead assay, because this is a better form of performing the test. So then what is DIC? DIC is simply a syndrome where you have a variety of serious and life-threatening complications. Usually it is a hemorrhagic disorder characterized by multiple ecchymosis, mucosal bleeds. You may have simply bleeds in the skin and from the oral mucosa. You may have bleeding from coughing. You may have Ryle's tube bleed, or you may have melena, or you may have bleeding into the Foley's. It may just be mucosal bleeding. Or it could be bleeding that is unexpected from usual unexpected sites, or it may not be present as bleeding, but you may just find that there is a lot of abnormal lab on a routine testing. You may have depletion of platelets, and when you do a coagulation profile, you find that there are abnormalities in the test. So it may be present clinically evident to you by bleeding, or it may be manifest subtly in you if you do certain tests. So this is simply DIC. So let's look at DIC in a greater detail. That tells you that tissue factor is very, very essential, and this causes a lot of these factors. But what we need to understand is that the endothelial cell and the monocytes are also important in the pathogenesis of DIC. So infections, you know, they activate monocytes, they also damage endothelial cells. Malignancies damage endothelial cells, also activate monocytes, because monocytes help in reducing certain abnormal cancer cells, and vascular lesions also. So realize that the monocytes can also release the tissue factors. The endothelial cells can also release the tissue factors, but also endothelial cell damage per se activates plasmin. And that is why whenever you have a widespread damage of the endothelium, you could have a lot of plasmin that is being formed, and this could lead to a lot of bleeding. Let's look at thrombin generation here. We know that thrombin generation will lead to a lot of intravascular fibrin clot formation. And when you have an intravascular clot formation, that interrupts the blood supply, and therefore you will have thrombosis of the capillaries, and this leads to tissue ischemia. But it also causes forcing of the RBCs to move through a very, very narrow space. So when the RBCs get sheared through this smaller space, they either lyse completely and cause hemolytic anemia, releasing a lot of LDH, or they become misshapen, which we identify as cystocytes on a peripheral smear, which we look up subsequently. In addition, we understand that the thrombin generates a lot of activated platelets. So that leads to a lot of platelet consumption. We did talk about the new cellular model where thrombin generation simply doesn't break down fibrinogen to fibrin, it also activates a platelet. So when you have a lot of platelet activation because of thrombin formation, platelets are consumed, so you have a consume coagulopathy, especially a platelet depletion or thrombocytopenia, and this causes bleeding because the primary step in arresting bleeding is a platelet plug formation, and if the platelet is not being allowed or present to form an adequate platelet plug, you will have bleeding. Let's look at a case. So a 31-year-old primee who was a term normal delivery with profuse bleeding soon after delivery, including from venipuncture sites, which means you do have a lot of bleeding from unusual sites, rapidly getting well, hemoglobin is slightly low, platelet is very low, urea creatinine is normal, and ALT is 93. So platelet is very, very low in this particular patient. So what causes DIC? A lot of causes. Any of these obstetric causes can be DIC, acute DIC or chronic DIC. A dead fetus causes chronic DIC, but acute DIC is caused by abruptio placenta, abortions, just plain hemorrhagic shock from an atonic pH or amniotic fluid embolism. You have a lot of infections, any bacterial infection, any viral infection, rickettsial infection can cause DIC. Likewise, chronic DIC is formed from osteomyelitis and tuberculosis. Malignancies, especially acute promyelocytic leukemia, causes acute DIC, whereas other malignancies can cause chronic DIC. And snake venom, spider venom can all cause chronic acute DICs. Mostly trauma will cause DIC, and that is exactly what propagates bleeding in trauma. When you have trauma, you have bleeding, and because you have bleeding, you have DIC, and because you have DIC, you have bleeding more. So this causes propagation of bleeding, and this is what is called as trauma-associated coagulopathy or TASH. Let's look at massive hemorrhage, which by itself causes DIC. So massive hemorrhage is defined as a loss of blood volume over 24 hours, but you can't wait for 24 hours to define massive blood volume, so you need a smaller period of time. So we say that if you lose 50% of the blood volume in 3 hours, we can call this massive hemorrhage, but that is still a longer time. And therefore, if you have an estimated blood loss of 150 ml per kg, it's called massive hemorrhage. Or in a pediatric population, if it's 1.5 ml per kg per minute for more than 20 minutes, this is massive hemorrhage. Remember that if you have massive hemorrhage and if you don't replace this adequately, this itself will cause DIC. In fact, one of the commonest causes of DIC in India is not snake poisoning now, is trauma and trauma-related massive bleeding. Unless you assess and adequately treat this massive bleeding, you cannot be treating hemorrhage at all. And remember that when you treat the hemorrhage, obviously the hemorrhage per se can cause a lot of problems, but the treatment that you do can also cause coagulopathy and DIC. Like you inappropriately transfuse, you transfuse a lot of crystalloids, you give only a certain blood product and don't replace all the blood products, that itself will cause a dilutional coagulopathy. And remember that if you lose a lot of hydroxyethyls and gelatins, that itself causes coagulopathy. So how do you diagnose DIC? Clinically, by multiple bleeding sites, ecchymosis, visceral hemorrhage, and ischemic tissue. As you can see here, ecchymosis, skin into the tissue, and this could be gangrene. So this is the ischemic variety of DIC. So how do you diagnose DIC? We diagnose DIC clinically. However, you can also use labs. As we said, any of the lab parameters like PT, APTT, CT, fibrinogen, etc. will be able to help you make a diagnosis of DIC. Platelet count is decreased as a rule, but remember the platelet count may be still falling from normal because the platelet count is 1.35 to 3 lakhs. It may drop from 3 to 2 lakhs, and you may still think that it is not DIC because it's in the normal range, but it may be falling from a normal range. So don't be misled by a platelet count that is not yet fallen to a very low level. And this is what we call as cystocytes. Can you see these are normal RBCs and these are crenated RBCs which have become crenated because they were sheared through a clot reduced space in the blood vessel. So this is a DIC score. As you can see, it looks at the platelet count, the FDP or the D-dimer. It takes only the PT, not the APTT and the fibrinogen levels. And if you have a score of more than 5, it is called DIC. And how do you treat the DIC? You recognize and treat the underlying condition. If it's obstetrics, the obstetric condition. If it's infection, the infection has to be treated. If it is trauma, the trauma has to be treated. If it is massive hemorrhage, the hemorrhage has to be treated. So the treatment of DIC is treatment of the cause. And blood product components as needed. If you have ischemia, you could give heparin only after you've corrected the bleeding risk with appropriate anticoagulants. Packed cells, it raises hemoglobin by about 1 gram. Platelets, usually 1 unit per 10 grams, 10 kgs of body weight, which means for a 60 kg man, you'll use 6 units of platelets. FFP, usually no compatibility test required. And cryoprecipitate if you want to replace fibrinogen and factor 8. Remember that there's no role of fresh blood. And obviously, with these massive transfusion, you do have TRALI, allergic reactions, and also a lot of infections. So you would check the CBC, PT, APTT every 6 hours, transfuse to keep the hemoglobin around 8 by using appropriate RBCs, transfuse to keep the platelet above 30, need not keep it to about a lakh, about 30 to about 50 may be enough. Keep the ratio of PT or APTT less than 1.5 by using appropriate FIPs. And the normal fibrinogen levels is 200 to 400, but it will suffice for you to keep the fibrinogen more than 100 by using appropriate cryoprecipitate. Obviously, replace calcium, keep the patient warm, and monitor urine output. Avoid IM injections, and central line should be placed in compressible sites, so either the femoral or the jugular, never the subclavian. Avoid aspirin and NSAIDs. And obviously, there may be a role for tranexamic acid, except in hematuria where it is contraindicated. Maybe there is a role of NOVA7, but clearly, no role for 4-factor PICs. Thank you all for your patient hearing.
Thank you, sir, for your descriptive talk on DIC. Any questions from the delegates? You can ask 1 or 2 questions. Okay.
So, role of heparin in DIC.
The role of heparin in DIC is, in one of those patients, we do have a thrombotic manifestation of DIC where you have a lot of clot formation. In these particular patients, if there is no active bleeding and we know that there is DIC, then you may have a role for heparin. Here again, you give heparin by keeping the platelet count in 30 to 50,000 and a safe range, and give heparin and keep monitoring the APTT every 8 hours, and also the other coagulation factors just to see that they are not worsening, and obviously stop if they are bleed. Usually when we use heparin for treatment of DIC thrombosis, we usually target a higher APTT, which is usually 60 to 90, but here we'll target a lower APT, which is around 45 to 60. Over 1 day, if you find that with 45 to 60, there is no bleeding, then we are more confident, and then we will go to maybe target to 60 to 90 and take it. But, well, that will be a very great challenge to treat patients with thrombotic DICs, because patients with thrombotic DICs usually are chronic DICs.
Okay.
Because there is, in acute DICs, because there is an acute consumption of clot, there is bleeding. So so there's no chances of clot being the predominant manifestation. So clot formation and ischemic DV form of DIC is more chronic DICs, so definitely more difficult to treat. If the underlying condition is being treated, then you could use heparin after you've corrected the coagulation factors.
Okay, sir. Thank you.
So just one more thing. I think in DIC, the earliest diagnosis is very important. So how to identify the DIC in the earliest period? So is there any clinical or biochemical spectrum from which it progresses?
Okay, so as he said, DIC is very difficult to recognize early on. So we'll have to suspect DIC in the appropriate context. As we put in there, we needed what are the conditions that can cause DIC. Obviously, you'll have to keep an antenna very high if you're dealing with trauma, if you're dealing with acute infections which have got multi-organ involvement, and whenever you're dealing with obstetrics. Wherever you have a lot of tissue factor release, like in trauma, like in obstetrics, and hemorrhage of whatever cause, there DIC is very much possible. So we need to keep an antenna very much high, because the only way most of us recognize DIC is when the bleeding happens. That is, when the patient bleeds, then we reflexively try to find out why this particular patient is bleeding and repeat a lot of tests and then find that this is DIC. So we do have probably keeps the antennas high in these situations, and maybe look at appropriate tests to see whether they are abnormal. A falling platelet from an original value may foretell that there may be a DIC. But having said that, if you're going to even find it, we are not going to treat DIC unless there is bleeding or extensive clot formation. So yes, we may recognize that will help us to keep our blood bank informed if you need, but otherwise in the terms of management of a patient, it may not. So unless in trauma or obstetrics where early recognition is very, very important, in other conditions like sepsis, then it may not really be useful for us to make a diagnosis upper hand.
Thank you, sir. Thank you very much. Sir, one more question to Dr. Sivakumar, sir. As a general practicing clinicians, so what you will advise at the practice level for the individual doctor to follow about this antibiotic stewardship, not at the corporate hospital or at a multi-specialty? So what are the main things an individual doctor has to practice, and among his paramedical staff, what are the things he has to implement strictly? Just enlighten us.
First of all, in an outpatient practice, I think we should stop using antibiotic where you know that it is a viral prodrome. So probably like many of you, upper respiratory tract infections, if you know it is clearly a viral, probably you should stop, avoid using antibiotics. And the other area where there is a lot of abuse is the emergency room or casualty. There, I think that is one ignored area where people come in and the antibiotics are prescribed. These are, apart from ICU, these are two areas probably we should think about minimizing, at least for when you're sure that it is mostly a viral illness.
I think this antibiotic stewardship should not be a job of the doctor. It should be looked after the whole paramedical team. So everybody should be educated, or the knowledge should be dispersed to all the paramedical staff, and they should be also encouraged to ask every one of the team to decide whether this antibiotic is needed or not at this situation. So I think that will also go way ahead in control of this antimicrobial resistance.
So another problem after COVID, most of the patients, they are taking azithromycin for 2 to 3 days, then only they come to us. This is a common misuse of antibiotic. This led to antibiotic resistance. So this is another problem we are facing now. I think you agree with it. Most of the patients.
I think it has become it's a household drug. Now everyone start to, whenever there is a sore throat or everyone tries to use azithromycin. The other aspect which Ravi was trying to highlight is a clinical pharmacist. I'm sure, I think it is not available everywhere. There one paramedic, probably they could help us in a big way in implementing antimicrobial stewardship, because they have a good domain knowledge and they will be particularly looking at stewardship. So at least wherever possible, I think if hospital could share and use clinical pharmacists, I think they will have a huge impact not only in stewardship and many other aspects in the way we prescribe drugs.
Thank you, sir. I think we can close the session for now.
Thank you for your thought-provoking speech, sir. It was indeed a great presentation. Now I welcome Dr. Palanisamy, sir, Senior Anesthesiologist, to honor and present mementos for our chairpersons and speakers.